departmental meeting. So we have a suite of cases from the divisions of geriatrics, the EU, and dermatology today. Before we start, I would like to remind everybody that we are now capturing attendance for these meetings and therefore able to credit people for continuing professional development points. I'm grateful to Sohana Ranglal for having circulated an email earlier indicating a link that you can click on to indicate your attendance at each of these departmental meetings so that you can get your CPD points. I would now like to invite Ruan Marais to just take a few minutes to provide an update on a study that he's doing. Ruan?
Hi, thanks for the opportunity. I'll share a few slides and just have a few minutes of chat just to let everyone know about a study that myself in the Department of Virology has undertaken with the collaboration with the Department of Neurology.
Ruan, do you mind just speaking up a little bit? Your mask is
sorry.
muffling your voice.
All right, are my slides visible? Okay, so we are undertaking a project, the application of metagenomic sequencing for the etiological diagnosis of central nervous system pathology in COVID-19. Basically what that is agnostic sequencing. What we'll be doing is taking CSF samples and doing agnostic, unbiased sequencing to detect any and all pathogens within the sample. Specifically, we are addressing it for CNS pathology related to COVID-19. So who would be eligible for this? Any adult patient with a neurological syndrome that justifies a LP being taken, and the patient must have a prior or current COVID-19 infection based either on clinical criteria or molecular testing, or the patient must be a PUI at the time of presenting to healthcare. What that basically means is any patient that needs an LP for diagnostic purposes that has had a SARS-CoV test is eligible for inclusion in the study. And hopefully we can generate data that is far more broad in terms of CNS diagnostics. So if you have an eligible patient, please contact me. My number is on the screen, or the virologist on call can be contacted via switchboard, or the NHLS lab virology laboratory through the NHLS can be contacted. Everyone in the lab is aware of the study in virology, so should be able to make me aware of the patient. Ideally, it would help if I am aware before the LP is taken, for the sole purpose that I can get the CSF into processing faster. But if the LP has already been taken, that is also fine. If it has already been sent, that is also fine. I just obviously would like to know about any of those patients and see if they would be eligible for the study. That's it. Any questions?
Thanks, Rowan. So perhaps I can ask people to put their questions through the chat function and ask you to respond there if there are any questions. All the best with your study.
Thank you so much.
So if you can, oh, wonderful, you've already unshared. Next, I'd like to invite Graham Menkes to make a brief announcement about the clinical service. Graham?
Thanks, Ntobeko. Just very briefly, just a reminder to all colleagues currently working on the G floor at Groote that from the beginning of October, we instituted a policy that every patient being admitted to the general medical service should be screened for SARS-CoV-2 infection. And Peter has been keeping the stats on that. What we showed in the first week of October was the proportion of patients that were screened was in the 60%. The second week it was 79%, so it's improving. Obviously, there will be some people, some patients who decline testing, and that's their right to do that, but we still feel that we could increase the proportion that are being tested, so we want to encourage everybody to test to offer a test to every new admission. The importance of this is obviously for the individual patient care. The sooner we get to know about a positive diagnosis, the person can be moved to a COVID ward and reduce the risk in the ward in general. And it's also important to inform our response to a potential second surge. It'll allow us to pick that up a lot earlier. And then, we will look at this data at the end of October and make a decision as to whether we continue with this universal testing policy. So just to really encourage everybody to follow the policy, because it will help us both in terms of infection control, but also guiding our response. Thanks, Ntobeko.
Thanks very much, Graham. So I would like us to move into the program for today and invite our first speaker, Mark Combrink, who is giving a presentation on behalf of the Division of Geriatrics, and his presentation is titled Parkinson's Plus, a CT Scan. Over to you, Mark.
Thanks very much, Ntobeko. Are my slides showing? Okay, thanks very much. Okay, good afternoon. I'd like to present the case of a man with Parkinson's disease who underwent a CT scan. And the point of the case, I think, is to illustrate the complex and often multifactorial nature of disease in older patients, and also to raise the question as to what to do with incidental findings on brain imaging. So the patient, Mr. CJ, is 82 years old. In fact, he works at Groote Hospital as a chaplain and has been doing so for the past 30 years, but had to stop work in March with the COVID lockdown, and of course his age as well. He is a lifelong non-smoker and teetotaler. He has had hypertension for the past 12 years, but no reported target organ damage. He's also been diagnosed with dyslipidemia. There's no history of vascular disease, either cardiovascular, cerebrovascular, or peripheral vascular. Last year, he had a TURP for benign prostatic hypertrophy. In January of this year, his general practitioner diagnosed depression, and his current medication comprises the list shown there, including escitalopram, which is a SSRI antidepressant, 3 drugs for hypertension, losartan, amlodipine, and bisoprolol, also half an aspirin a day, simvastatin, and a combination drug containing orphanidrine and paracetamol, which he uses for muscle cramps. In addition, he's also on a benzodiazepine, clobazam, 10 milligrams at night. His primary symptoms relate to deteriorating mobility in the last 2 years. These symptoms were of insidious onset and slow progression. His family observed that his stride length had become shorter and that his gait was increasingly shuffling in nature. He had difficulty initiating movement, reduced ability to perform fine movements such as fastening or loosening shirt buttons. His handwriting had deteriorated and it had become smaller, and his voice was softer than usual. His mood was low, he appeared apathetic, and his motivation, according to his family, had become poorer as well. He no longer enjoyed his usual hobbies, he slept poorly, his appetite was reduced, and he'd lost a few kilograms of weight over the past 2 years. However, he had no specific cognitive symptoms, and his activities of daily living, both basic and instrumental, were intact. On physical examination, his pulse was 70 and regular. He had a systolic hypertension with blood pressure of 173/79 with no postural change. Examination of the heart, lungs, and abdomen were normal. On mental state examination, he had depressive symptoms, but no psychotic features. He was anxious. His speech was hypophonic. He had a mild dysarthria. He had reduced facial expression, and his affect appeared blunted as well. He had a positive glabellar tap and a tremor of his lower lip. He had a typical Parkinsonian supination, pronation tremor involving the left forearm. He had extrapyramidal lead pipe type increase in muscle tone bilaterally in the arms and the legs, more so on the left than on the right. He had bilateral cogwheel rigidity at the wrists, again, more on the left than on the right. But interestingly, he had clonus at the left wrist. And clonus, as you know, is usually considered to be an upper motor neuron pyramidal rather than an extrapyramidal sign. He had bradykinesia. There was reduced amplitude and frequency of rapidly repetitive movements at the fingers and at the hands. His deep tendon jerks were symmetrically brisk. His plantar were flexor. He had a slightly stooped posture with reduced arm swinging on the left side. Sensation was intact. On cognitive testing, he scored 23 out of 30 on the mini mental state examination, losing points with attention, copying of the pentagons. He lost 1 point on the 3-stage command, and he was only able to recall 1 out of 3 objects after a short delay. On the Montreal cognitive assessment, he scored 18 out of 30 with features of frontal or frontal subcortical cognitive deficits in keeping with a dysexecutive syndrome. Here's the classic clocks test, which we often do. On the left side is his clock drawn to verbal instruction. You can see it's poorly planned. Most of the figures go down one side on the right, and the figures seem to bear little relation to the circle which is drawn. However, on the left-hand side, you see his clock copied from mine. His copied clock is in fact much better than the one drawn to instruction, and this indicates executive dysfunction rather than a visuospatial problem as well. And then the rest of the mocker, I'll just highlight his recall. So his immediate recall, or learning of 5 words, was normal, but he recalled none of them after a short delay. However, with prompting either by category or semantic clues, he was able to remember 4 out of the 5 words. And this is typical of a dysexecutive dysamnesia, as opposed to an axial amnesia. There's another classic test of frontal lobe function of motor program sequencing, known as the Luria 3-step test. The patient has to place his hands sequentially in the 3 positions illustrated on that diagram, and it's considered a test of praxis and left frontal lobe function, and he was unable to perform this with either hand. Sorry, I'll leave the videos, don't worry about that. So in summary, we have an 82-year-old man with systolic hypertension, depression, and features which I thought for the most part were consistent with the diagnosis of primary idiopathic Parkinson's disease. Not only that, but it was also levodopa responsive. Prior to my seeing him, in fact, I'd advised his GP to try L-dopa while they were waiting for the clinics to reopen. And in fact, his GP, his family, and the patient himself all commented on the noticeable improvement in his mobility after starting L-dopa. But there were a couple of things that didn't quite fit. Firstly, this clonus at the left wrist, this upper motor neuron sign, as I pointed out. And secondly, the cognitive deficits, these dysexecutive frontal subcortical cognitive deficits, which you can indeed get with Parkinson's disease, but they usually occur late in the disease after several years. So we don't usually perform scans routinely on patients with Parkinson's disease, but I thought those facts were provided some justification for doing so. And I put my foot in it, as I say. So here are the scans, if you don't want to look at the results, as I say on TV, look away now. On the left-hand side, you can see a standard axial CT scan showing, I don't know if the pointer works, periventricular white matter disease, mainly in the periventricular area, but also extending into the deep white matter and the subcortical white matter as well, in keeping with small vessel disease. And then on this scan, taken at the level of the frontal sinuses, you can see an area of calcification adjacent to the frontal bone, with a suggestion of possible edema around it as well, and rather suspicious for a calcified meningioma. But the question is, was it really that? And so one investigation leads to another, and now he gets an MRI scan. Again, you see the white matter changes quite clearly and more spectacularly, the hyperintensities on the FLAIR images. No surprises there. We saw that on the CT. And then this was the CT I showed earlier on the left. On the right-hand side, on the gadolinium-enhanced MRI scan, you can now see what looks very much like a meningioma, enhancing homogeneously in the left frontal lobe, and also with the appearance of a dural tail attached to the dura. And that's quite a characteristic appearance of a meningioma. But that's not all. He also had a susceptibility weighted image on the MRI sequences. And this showed, I don't know whether you can see these little dots scattered around in the brain, punctate, so-called blooming artifacts, as they're called, scattered throughout the brain. I've just shown one view, one cut there, more peripherally in the grey-white matter interface and centrally. And this usually indicates hemosiderin, and it means previous microbleeds or microhemorrhages. So now we've got a lot more than we started with. I still think he has primary idiopathic Parkinson's disease, given those earlier signs. But he's got cerebrovascular disease with so-called vascular Parkinsonism, or vascular pseudo-Parkinsonism, if you like. But he's also got another form of cerebrovascular disease, which is those microhemorrhages that are typically seen in the condition of amyloid angiopathy. And he's got a left frontal meningioma, and he's just depressed. And so his dysexecutive cognitive impairment may in fact be secondary to all of the above. Just to add insult to injury, he's also on some drugs that can worsen cognition, particularly in older people, benzodiazepines and anticholinergic agents. So what's the role then of this left frontal meningioma in these symptoms and signs? Is it causative? I don't think it's only cause necessarily. More likely it's contributory, that there are multiple factors of which the meningioma is one. They may even be synergistic. These factors may interact with each other, with one another, so that a single factor on its own, or of its own accord, doesn't cause this symptoms and signs, but working in concert they do. Or is it just incidental? We know meningiomas are quite common incidental findings on scanning. So that brings me to the short discussion about what do we do with these incidentalomas? What do you do with an incidentaloma early in the morning? What is it first? It's an apparently asymptomatic intracranial abnormality, but of potential clinical significance, seen with increased use of scans for various purposes, not just clinical and diagnostic, but in research and so on as well. It's an unintended consequence of imaging in a clinical situation, and it's become a topic of increasing interest as imaging has become more widespread, and also as older people are increasingly scanned as well, because most of these, or many of these things, occur predominantly in older people. So they come in different forms. Those are the incidental brain findings that are described on MRI. So we've seen those markers of cerebrovascular disease, white matter changes, silent infarcts, microbleeds in his case, and neoplasms amongst other things as well. Of the neoplasms, by far the commonest is the meningioma, followed by the pituitary adenoma, and then various other structural vascular abnormalities, inflammatory lesions, cysts, and other congenital malformations may be seen as well, incidentally. And this slide just shows that they increase with age, particularly the white matter hyperintensities and silent infarcts, but also the neoplastic lesions, although it's not clearly shown in the graph there. So what do you do with these things? Do you treat them? Do you just observe them? But we don't actually know the natural history often of these conditions. And the risk of an intervention like neurosurgery may be worse than actually leaving the lesion alone, especially in older patients with comorbidities. Anxiety is obviously provoked by these findings, and there's a costly cascade of investigations that usually follows, and there may even be consequences for the patient, such as if he has to declare it on a life insurance policy, for example. So just a word about these meningiomas, actually, because more and more is becoming known as more and more longitudinal studies are performed. So in older people, by which I mean over 65, 94% of asymptomatic meningiomas remain asymptomatic. 63% do not grow significantly, by which they mean less than 2 millimeter increase in size over the year. They grow more slowly in older people, and surgery, of course, carries a fairly high risk of morbidity, especially in the elderly. But the other good news is that highly calcified lesions are especially slow growing, and these also typically occur in older people. There's some evidence that the site of the meningioma is also important. So just to finish off, what have we done? We've continued his medical therapy, including his antidepressant, but we've stopped the drugs that we think may be worsening cognition. The question of what to do with the aspirin is unanswered, really. He's got a propensity to form microhemorrhages because of the amyloid angiopathy, but there are no studies really to indicate that people on aspirin have a higher likelihood of sustaining intracerebral bleeds than those not. I've actually told the patient about this finding, and I've downplayed it and stressed the benign nature of it. And obviously, you'll be monitored for symptoms of headache and raised intracranial pressure and be rescanned in a month's time. Very quickly, there are different kinds of small vessel cerebral disease as well. There's a classical arteriosclerotic lesions, which are the fibrinoid necrosis, the lipohyalurosis, and so on, which are age-related and also vascular risk factor-related, occurring typically in people with uncontrolled diabetes, hypertension, smoking, and so on. And these are the classical periventricular deep white matter and subcortical white matter low-density changes that you see on the CT scan, often with associated lacunar infarcts in the basal ganglia, thalamus, and internal capsule. But what he also has is this other form of small vessel disease, which is cerebral amyloid angiopathy. And there's a whole literature on this as well, and there's various kinds of them, some of which may be quite aggressive and inflammatory in nature and may respond to steroid and immunosuppression treatment. Suffices to say, there are genetic and familial forms, well-known forms described, often called Dutch type cerebral amyloid angiopathy or Icelandic type cerebral amyloid angiopathy. But in his case, it's probably just age-related. And in fact, it suggested that up to 50% of patients of people undergoing post-mortem examination, brains being examined at post-mortem, show amyloid angiopathy in people over the age of 65. Sorry, people over the age of 70. And those are these gradient echo or susceptibility weighted imaging, these microbleeds that you've seen on the scan. So thank you very much. I'll stop there. Neuroimaging has obviously added a new complexity to medicine in general and to medicine of old age in particular. But as more longitudinal studies develop, I'm sure decisions about what to do with these incidentalomas will become more evidence-based. Thanks very much. Thank you.
Thank you very much, Mark. That was very, very instructive presentation. I wonder if there are any questions for Mark. I don't see anything in the chat function. I guess I can ask a quick question, Mark. So you've labeled the title of the talk Parkinson's Plus. And I wondered if you thought this was multisystem atrophy or dementia with Lewy bodies or corticobasal degeneration peaks or any of those spectrum of Parkinson's plus. Would you have expected a response to the levodopa?
No. To Baker, that was a play on words. It was Parkinson's plus a CT scan.
Oh, sorry.
No, I think this is primary idiopathic Parkinson's disease, together with lots of other pathologies, but not one of those other Parkinsonian syndromes like multiple system atrophy or progressive supranuclear palsy or corticobasal degeneration or Lewy body dementia or anything like that.
No, thanks, Graham. You've got a question?
Yeah, thanks, Mark, for the case. Just to ask you if you can just remind us, in terms of diagnosing cerebral amyloid angiopathy, other than the MRI, is there anything else on CT scan or clinical presentation that would help to differentiate it from atherosclerotic disease?
Yeah, yes. The short answer is no, really. CT scans don't show any of it. In fact, I think we miss a considerable number of cerebral amyloid angiopathies because we routinely don't do MRI scans. Not that we particularly want to in older patients with suspected cerebrovascular disease. So it's really become an MRI diagnosis. But there are, I suppose, some clinical features. Firstly, the familial forms. Those are very distinct syndromes, typically strong family histories of intracranial hemorrhages, of intracerebral bleeds. And then, as I mentioned, there's often an aggressive form of the condition in which patients present with not just cognitive impairment, but seizures, headaches, even focal neurological signs, depending on the sizes of the lesions. And they often have an inflammatory cerebrospinal fluid profile as well, with polys and lymphocytes and raised protein. And that particularly aggressive form of amyloid angiopathy, which tends to occur in younger patients as well, responds, in some cases anyway, to steroids and immunosuppression therapy. But the short answer is no, it's become it's an MRI diagnosis by and large.
Thanks.
Thank you very much, Mark, and thanks for the presentation. So I'd like to move on to the next lecture and invite Gordon Robertson from the EU to present to us. The title of Gordon's presentation is Central Airway Obstruction. Gordon, would you like to upload your presentation? Wonderful.
Hi, I'm Gordon Robertson. I'm a MO in medicine, currently working in 15. Can you see my slides?
We can see your slides. Would you mind putting up your video as well?
We don't. Prof, we don't have a camera on this computer, unfortunately.
Go ahead.
Sorry about that. So I'm going to talk about central airway obstruction, which is quite an unusual presentation of a number of conditions that I've seen a few of now in the last few months. I'm going to present two cases, both of them slightly different in their management and in their presentation. So the first case is Mr. DM. He's a 71-year-old male. He's diabetic on metformin only, a very significant smoking history of 30 pack years, functional class ECOG 2 as a baseline. He's presenting complaint with 6 weeks of unremitting cough without blood, with progressive dyspnea, with acute worsening to dyspnea at rest of the last few days associated with stridor. His vitals were relatively normal with a mild increased respiratory rate. And on examination, he had only had inspiratory stridor, but it was also quite intermittent. If he coughed and expectorated sputum, the stridor would actually disappear. And then in the next 10 minutes or so, it would appear again. So this is his x-ray. It's projects really badly. I try to play with the contrast to show what the problem, but okay, so he's had previous surgery to his C-spine. That's just hardware that you see at the top. But the most striking thing, which again doesn't project too well, is that one cannot actually see his entire trachea at all. It almost looks like there's an occlusion at, we thought actually at the level of the distal trachea carinal area, as well as the left main bronchus. So because he was a stable patient, we went on to do a CT chest. CT chest showed a very large, so in the coronal section showed a very large subcarinal mass, which is encasing the left main bronchus, and also looks like invasion of the left main bronchus, causing an irregular wall of the bronchus, as well as narrowing of the left main bronchus. It's also interesting to note, although we were very worried about the distal trachea is actually completely unaffected on the CT scan. And here in the, you can also see it's the same problem there with severely restricted left main bronchus. So his follow-up, he was admitted to the ward to medicine. He had a rigid bronchoscopy done by cardiothoracics, where there was a splaying of on the bronchoscopy, they visualized splaying of the carina with a left main stem bronchus mass lesion. A biopsy was taken. It showed poorly differentiated squamous cell carcinoma. He was admitted, unfortunately, for palliative care and palliative radiotherapy for symptom relief in oncology. And the second case, which is a slightly different case, is Mrs. SM. She's 55 years old. She's obese, hypertension, which is newly diagnosed and not yet treated. Prior to her presentation in C15, the 2 months before her presentation, she presented to the surgical endocrine department with hypothyroidism and a large goiter. Thyroid ultrasound at the time showed a mass likely thyroid in origin with some benign looking nodules. FNA was done of these nodules. It showed a lymphocytic infiltrates and suggested of lymphocytic thyroiditis. She didn't have any compressive symptoms, so a watch and wait approach was chosen. So over the next 2 months, she had progressive enlargement of this goiter. And a day before her presentation, she developed noisy breathing at home, specifically when she lay flat and when she was trying to sleep at night. EMS arrived because of her worsening shortness of breath, and they realized the patient was very, very anxious. So they gave us midazolam to try to calm her down. The patient became sedated, developed severe stridor, and became severely hypoxic, which was correctable with non-rebreather oxygen. So when she arrived with us, her raised respiratory rate with oxygen saturations of 94% on nasal prong oxygen. She was completely unable to lie flat without developing stridor. She was most comfortable sitting up at 45 degrees. By the time she got to us, she was less sedated, so her oxygen saturations had improved. Clinically, she had a massive anterior neck mass with no obvious signs of a superior vena cava syndrome. So I just want to show you her x-ray. So in her AP chest x-ray, you can appreciate the very, very large neck mass, as well as deviation of the trachea to the right with severe stenosis of the proximal part of the trachea. On the lateral neck x-ray, which is actually a very important x-ray to have if you want to intubate these patients, you can see that it's not only was the trachea deviated to the right, it's also there's mass behind the trachea, pushing the whole entire trachea and larynx forward, which will make this, if you try to intubate this patient just with a normal laryngoscope, this is going to be a very difficult intubation because of the incredibly anterior larynx, not also in keeping with the huge mass that you need to be able to push forward. So this will be a very difficult intubation. So we did a CT neck and chest for her, which showed a very large mass, still thought to be thyroid in origin, encasing both the trachea as well as both jugular veins, as well as cervical lymph nodes. They actually thought the mass looked malignant in origin based on the CT. So in C15, she had developed worsening stridor. Decision was made to intubate her. It was a difficult intubation, was assisted by the anesthetics and the airway team. She was admitted to surgical ICU, where because of the CT findings, revision of the diagnosis was necessary. So a core biopsy was done, which actually showed diffuse large B-cell lymphoma, which she was then started on methylprednisolone. While waiting for that histology results, she started on chemotherapy, which was R-CHOP. She was extubated actually day 9 ICU, uneventful stay in the ward after extubation. I actually followed her up last week at hematology, where she's completely back to baseline. The mass has shrunk. She's doing very well. She's receiving chemotherapy as an outpatient. In terms of her cancer, she's still got a way to go with her cancer, but she's actually doing really well and has a very good outcome. So I'm going to talk about briefly just talk about airway obstruction. So there's three major types. There's upper airway obstruction, which is mouth, nasopharynx, larynx, and subglottis. There's central airway obstruction, which is airflow obstruction in the trachea and bronchi. And then there's lower airway obstruction, which is distal to the mainstem bronchi. So I'm only going to talk about central airway obstruction. So the defining sign is stridor. So there is a grading system for stridor with 4 different grades. I'm not going to go into them because I do not feel that the grades are particularly useful in a clinical situation. So I feel the most important thing is if there's a patient has stridor is whether they are stable or unstable. Do they have respiratory compromise or do they not have respiratory compromise? And that will define management more than the grade of stridor. So the most common way of presenting with a central airway obstruction is actually progressive dyspnea, cough, hemoptysis, and a monomorphic wheeze. This is, most of the patients will present like this. They often have multiple presentations to their, to various doctors and emergency centers. And they're mostly misdiagnosed as asthma, COPD, pneumonia, or bronchitis. To note about the progressive dyspnea, dyspnea at rest will start when the stenosis of the large airways reaches about a size of 8 millimeters. So dyspnea at rest is already actually a really bad sign. Shows that it's a really far advanced stenosis. And stridor and respiratory compromise occur incredibly late in disease. Stridor needs tracheal lumen to be less than 5 millimeters or less before it starts to develop. All stridor, even if it's mild, needs immediate management and at least needs inpatient admission and workup. And often, stridor also can present as acute stridor, while it was actually a subacute stenosis that is now worsened by either infection or mucus or bleeding, especially in tumors. So the causes are generally in adults divided into malignant and non-malignant. In the malignant group, most of them are non-small cell lung carcinomas, which are either by direct invasion of the central airways or via extrinsic compression via mediastinal or hilar nodes. But it can be also metastatic or nodes from any other cancer. Non-malignant causes, so strictures, especially in the setting of previous intubations, causes often a proximal or subglottic stenosis, foreign bodies, and tracheobronchial malacia. There are also some rare causes. Trauma, interesting enough, is a rare cause. Just generally trauma that disrupts your tracheobronchial tree is quite severe trauma that usually leads to the demise of the patient. And endobronchial infections, which TB is one of them, which can also cause tracheobronchial malacia. So the general principles of management, respiratory compromise needs immediate airway management. Imaging should never ever delay the management of the airway. Bronchoscopy is a method of choice to facilitate intubation, diagnosis, and treatment. And it's actually more important in the acute presentation than any sort of radiological imaging. And unstable patients need airway experts to be involved. It's often far better in these patients to, especially if you're in a peripheral hospital or you're not at a center where there are experts immediately available, to rather just ensure oxygenation than worrying about a definitive airway. So like most of these patients with central airway obstruction will respond very well to supplemental oxygen and positioning them in an appropriate position that feels comfortable to them so that they can be transported to an area where they can be properly managed. And preferably these patients should actually be intubated in theater with a multidisciplinary team available, which will, the people involved in the team will depend on the exact suspected level of obstruction. And the intubation technique and backup methods will also depend again on the exact suspected location. Failed attempts at intubation can cause bleeding and mucosal edema and loss of the airway. So, and also muscle relaxation, you cannot use any muscle relaxants in these patients as it can cause a complete loss of airway due to decreasing the airway tone, especially in lower tracheal lesions. Awake procedures are preferred so a patient can maintain their own airway. So the general principle is you want to keep the patient awake as possible. So for example, a fiber optic awake intubation. Tracheostomies are often not useful. The only real setting that they are useful in is post-tracheostenosis due to previous intubation where the lesion is very, very proximal in the trachea, and then a tracheostomy is more useful, and often it's done also as an awake tracheostomy. But for the most part, tracheostomies are not useful. So useful adjuncts is, like I've just mentioned before, keep the patient in a position of comfort. You can use adrenaline nebs to help decrease edema if there were a subacute presentation now with added inflammation or infection. And for the same, in the same logic, you can also use high flow nasal oxygen as CPAP as a bridge until an expert help is there. As it's not really about the CPAP or the high flow nasal oxygen, but because these devices have properly humidified, warmed air, it helps with the secretions. And then you can also use nebulized lignocaine to facilitate airway maneuvers and bronchoscopy. So again, I've mentioned that bronchoscopy is the evaluation of choice. It helps to manage the actual airway and assisting intubation. It's also diagnostic with visualization and biopsy. It's also therapeutic. With these patients, you prefer to have a flexible and a rigid bronchoscopy available, as rigid bronchoscopy can actually be quite useful in patients with very large masses that you need to use the bronchoscope to, a rigid bronchoscope to push the mass out of the way, or for where there's a very, where the obstruction is a malignancy, a suspected malignancy, and you can use a rigid bronchoscope to core the lesion to actually get rid of the obstruction. The only patients that you do imaging first are for completely stable patients where you can do chest radiography and CT first. So the take-home messages is stridor is always an emergency, needs to be taken seriously and occurs very late in disease. Expert teams are always needed for airway management. Usually it's a multidisciplinary team, usually involving anesthetics, ENT, sometimes cardiothoracics and pulmonology as well. You must try to keep the patient awake as much as possible until definitive airways are placed. Avoid sedation, avoid muscle relaxants. Imaging should not delay airway management. And bronchoscopy is actually the first line of management. Reflecting back onto the second case I presented with a lady with a very large suspected thyroid mass with a DLBCL, I probably should not have taken her to CT for imaging first. She should have actually been intubated first, as even though I thought she was stable at the time, she did have stridor lying flat, and that could have potentially become a problem in CT scan, and there's no expert help to help you manage the airway. So ideally, she should have actually been intubated first. Okay, thank you. Any questions?
Thanks, Gordon, for that very clear presentation. Anna-Marie, would you like to comment?
Yeah, thanks very much, Gordon, for that really great talk. We wanted to really raise awareness about central airway obstruction. So when we've got lower airway obstruction like asthma and that, we know what to do, how to tube, how to ventilate. When we've got upper airway obstruction, we know that we can attempt to intubate, and then things like surgical cracks are able to be backup devices. When you've got central airway obstruction, that's actually a problem. The airway needs to be you need to be very respectful of that airway. The intubation plan for that airway is very different to most other intubation plans. You can get yourself into serious trouble with things like sedation and or muscle relaxants. You can lose that airway. And your backup plans that you would normally use if you lose an airway will not really work in central airway obstruction. So supraglottic devices generally don't work because the obstruction is lower. Things like needle cracks, surgical cracks, tracheostomies, they often don't work because the lesion is lower, or like in the second case, you're trying to go through a massive swelling in the front of the neck. So it's quite important to understand that central airway obstruction is its own problem, and that it needs a definitive airway that's done by a definitive airway, by an airway team that knows how to do it. We are fortunate, though, that central airway obstructions generally are subacute presentations that have just had something that's tipped them over. So generally, you can get away with oxygenation plans, like high flow nasal oxygen, humidified oxygen, and positioning the patient in the best comfort position while you get the patient urgently to theatre to get a definitive airway in before we start investigating. Radiology can help us, like x-rays. As you can see, both the patients that we presented, you could make a guess on the x-ray as to where the obstruction was, that you knew what trouble you would get yourself into, and that you knew that you needed to make some kind of an airway plan that was different to usual. And then the other thing to raise awareness about this is tracheal stenosis often occurs in people who've been prolonged intubations and ventilations for periods of time in ICU. And we're just worried with this post-COVID era for all those patients that were on ventilators for a long time that we may start getting a few of them coming back with tracheal stenosis. So we just would like people to be aware that tracheal stenosis can present with unusual presentations like ongoing wheezing or ongoing something like that. It's unusual presentations, and that's what we just wanted everyone to be aware of. Thanks.
Thanks, Anna-Marie. So this presentation is open for comments or questions. Looks like you've stunned everybody into silence. Thanks to both of you for that lovely presentation. And it's a pleasure to introduce the final speaker from dermatology, Dr. Sihan Wagid, who's going to be giving a talk titled Darling in Disguise. Please go ahead. Are you able to put on your video, Sihan?
I will afterwards, if that's okay.
Okay.
Okay. Good afternoon. The case I'll be presenting today involves a 39-year-old female who's newly diagnosed with HIV with a CD4 count of 1, and she presents with clinical symptoms of fever, cough, fatigue, shortness of breath, and loss of weight. The summary of her investigation showed an elevated liver function test, anemia. Her TB workup was negative, as well as a blood culture was negative. Chest X-ray showed a right-sided pleural effusion, and the ultrasound showed hepatosplenomegaly with no evidence of abdominal TB. She was then started on empiric TB treatment, and then on the 3rd of August was referred to dermatology with a 2-month history of a skin rash. On examination, you can see skin-colored nodules with central necrosis, and these nodules were confined to the face, upper limbs, and trunk. At this point, our differential diagnosis was, could this be a deep fungal infection, possibly histoplasmosis, cryptococcus, or amergomycosis? Could this be TB, myobacteria other than TB, or a secondary syphilis? We then did a skin punch biopsy for H&E as well as culture, and the biopsy showed mostly suppurative granulomatous inflammation, and the arrow depicts histiocytes with small little dots. A Grocott stain was done, and a Grocott stain usually stains fungi. And you can see again that these black dots are being demonstrated, and they're all fungi. A culture showed confirmed histoplasma capsulotum. So our assessment is at this stage is 39-year-old female, newly diagnosed HIV with a CD4 count of 1, started on empiric TB treatment based on clinical symptoms, now presented with a disseminated cutaneous histoplasmosis supported by histopathology and culture. She was then started on amphotericin B for 10 days and discharged on Rifafor and itraconazole. A month later, she was then started on dolutegravir, lamivudine, and tenofovir. So this will be my presentation outline. Histoplasmosis was first described by Dr. Samuel Darling in 1906, and it was called Darling's disease. Patients were described as presenting with features suggestive of disseminated TB. Histoplasmosis is caused by a dimorphic fungi, Histoplasma capsulatum, and there are 2 variants, the Africana variant Dubicii and Capsulatum variant Capsulatum. And they are found in caves, chicken coops, bird roosts, especially from soil deposits excreted from chickens, starling, and bats. With regard to the pathogenesis as depicted on the right side of the screen, histoplasmosis spores circulate in the air after contaminated soil is disturbed. These soil enter the lung through inhalation, and the body temperature allows the spores to transform into yeast, and these yeasts are engulfed by alveolar macrophages. Within the macrophage, the yeast cells multiply and then becomes disseminated through mitogenous spread. With regards to the epidemiology, histoplasmosis in Africa has markedly increased since the advent of the HIV and AIDS epidemic, but is often under-recognized due to the fact that it's not a notifiable disease. In South Africa, the most predominant infective agent is Histoplasma capsulatum variant capsulatum, and Histoplasma capsulatum variant dubicii is mostly found in Central and West Africa and is often referred to as African histoplasmosis. Oladal and others documented 470 cases from the period of 1952 to 2017, and in South Africa, 150 cases have been reported. However, it is possible that some of these cases was actually Amergomycosis africanus, which is endemic in South Africa. Oladal and others looked at the different clinical presentation of histoplasmosis in Africans, and they divided it into asymptomatic disease, where patients had no symptoms, and they were usually in immunocompetent patients, localized disease, which was more confined to the skin, disseminated disease in an immune-suppressed patient presenting with fever and constitutional symptoms, together with pulmonary involvement. And then you also get chronic histoplasmosis and progressive disseminated histoplasmosis. Primary cutaneous histoplasmosis is quite rare, with only 3 cases being reported in the literature, of which the 3 cases are actually in immunocompetent patients. They present with nodules, ulcers, abscesses, or molluscum-like lesions. However, there was only 1 case reported of primary cutaneous histoplasmosis in an HIV individual. The route of infection is through direct inoculation of spores through the skin through an abrasion in the skin. Disseminated cutaneous histoplasmosis in HIV, cutaneous manifestations are reported in 10 to 25% of AIDS patients with disseminated histoplasmosis, and cutaneous lesions is often the initial presentation. Again, they can present with nodules, ulcers, abscesses, and molluscum-like lesions, together with very non-specific symptoms. And only 50 to 90% of patients exhibit pulmonary involvement. The skin manifestations can be quite polymorphic. They can present with ulcerated nodules, molluscum-like lesions depicted on the left-hand corner. They can present with nodules, and even in the right lower-hand corner, they can present with psoriasiform-like plaques. They can also involve the mucosa and the palms. Diagnosis of histoplasmosis can be made with direct examination, such as on H&E, and you can also do fungal stains like PAS and Gros-Cot-Gamori methanamine silver stain, GMS. The gold standard is culture on SABS dextrose agar media at 25 to 30 degrees Celsius, and it's usually a slow growth of 2 to 8 weeks. Further testing you can do is antigen detection in urine and serum, as well as CSF, and you can also do serology and molecular diagnostics like PCR. The picture at the left side bottom is a picture of Histoplasma capsulatum on Sabarod's dextrose agar, and they describe it as being a white suede-like colony with a pale yellow reverse. And I'm just comparing how Amergomycosis looks, which is a cerebriform look with a powdery pattern. So with TB is the closest mimic of histoplasmosis and the leading opportunistic infection among South Africans. Like TB, histoplasmosis can also present with constitutional symptoms. However, in the context of HIV, although similar, there are some distinguishing features. In a study by Dennis and others, done in France over a span of 10 years, they looked at 205 HIV individuals, of which 99 had TB and 105 individuals had histoplasmosis. And they summarized the features associated with TB and histoplasmosis. As you can see from the table, they were both in immune suppressed individuals, except the more immunosuppressed you were, the more likely were to have histoplasmosis. And then anemia, high liver function test, hepatosplenomegaly, disseminated disease, and cutaneous manifestations were more commonly seen in histoplasmosis, where respiratory symptoms was more commonly seen in TB. So I won't go into too much detail with regards to treatment, although the Infectious Disease Society of America, ITSA guidelines recommend liposomal amphotericin B. I know in our clinical setting it is quite costly, and we are using deoxycholate amphotericin B. So 1 month later, the same patient that was discharged on the 16th of September presented again to us with a new ulcerated nodule with residual nodules on the rest of the face as depicted by the picture. At this point, we were concerned as to, is this a recurrence of histoplasmosis? Could this be untreated histoplasmosis or paradoxical iris? We then repeated a skin punch biopsy together with a culture, which confirmed histoplasma capsulatum again. She was then restarted on amphotericin B, and Rifafort was then stopped in consultation with ID. This brings me to this point, which is the drug interactions. So co-infection with TB and histoplasmosis occur in 8 to 15% of cases, especially in AIDS patients, and concomitant administration of rifampicin and itraconazole has become frequent. Studies, however, demonstrate that rifampicin and rifabutin significantly reduces serum itraconazole levels, which may result in loss of therapeutic efficacy of itraconazole. The drug is known to be a potent inducer of the hepatic cytochrome P450 enzymes, resulting in accelerated hepatic metabolism. Therefore, it is not recommended to be used together. There aren't many options with regards to replacing rifampicin, but there are limited studies that you could use moxifloxacin instead, but more studies are needed. And then furthermore, rifampicin also decreases plasma concentration of your NNRTIs and your PIs. My second last slide raised this case also. The patient presented with a clinical worsening of cutaneous histoplasmosis within a month after initiating antiretroviral therapy, which raised the possibility of a possible paradoxical iris. I then looked at the literature, and apparently only 3 cases of unmasking iris with skin manifestation of histoplasmosis has been reported, and all of them had systemic symptoms. So in conclusion, in the HIV and AIDS era, there are more reported frequencies of disseminated histoplasmosis. Mortality may be as high as 95% in untreated patients, and cutaneous lesions are often the first manifestation of disseminated histoplasmosis. And we should always just be aware of the drug interactions when prescribing TB treatment with antifungals. Thank you. Hello.
Rebecca, you on mute?
Sorry about that. I've been speaking to myself. Sihan, thank you very much for a very lovely presentation, very educational, and a nice pictorial review as well. Turaya, would you like to make some comments?
Thanks, Ntobeko. Thanks, Sian, for an excellent presentation. This was a very interesting case for us, as the patient initially was started on empiric TB treatment based on constitutional symptoms and chest X-ray findings, and subsequently was found to have histoplasmosis on skin biopsy. But both treatments had been continued, and only on representation, the question was then asked, could this all be disseminated histoplasmosis, or was this co-infection with TB? And in consultation with ID, we decided to treat it as disseminated histoplasmosis and stop TB treatment. I think the most important learning point from this case for us was the rifampicin and itraconazole interaction. And that rifampicin significantly decreases itraconazole levels, resulting in our patient then representing with new histoplasmosis lesions. And I'd like to ask Prof. Wasserman from ID if he could comment on this case, and also if he could advise us on what to do should a patient present with co-infection with TB. And I'd also like to ask Prof. Martins if he could comment on the rifampicin and
patients, because TB is more common, get started on TB treatment, and then we see them and the diagnosis of fungal infections made. And in our experience, and in Ilan Schwartz's series, cutaneous manifestations, at least of emergomycosis, are almost universal. So, you know, I think an important message is if you see a patient with a patient with advanced HIV and rash and fever, this has to be on the top of the differential diagnosis, and a biopsy has to be done. And so because of this drug-drug interaction, because of the difficulty of treating these things together, because itraconazole is really the drug of choice for maintenance therapy of these infections, we look very hard for this TB diagnosis and try and confirm it. If there isn't a lot of evidence for TB, then it's just really much safer to stop TB treatments and aggressively and optimally treat the dimorphic fungal infection. And that's what we did in this case. And I really think that the reason why the patient relapsed was because of very low itraconazole levels because of the interaction with rifampicin. If the patient does have confirmed or highly suspected dual infection, it's a very difficult problem because you can't use a rifamycin. So well, at least with itraconazole. So there's two approaches that we consider. The one is to give a rifamycin-free TB regimen. And it's a lot easier now because we've got much better drugs for, you know, we usually use for drug-resistant TB, or rifampicin-resistant TB, which this would functionally be. And so that's one option, you know, put a patient on short course MDR treatment for 9 months, which has very good outcomes. The other option, which we've done sometimes, is to continue the TB treatment, but to substitute the itraconazole for fluconazole, which is not a substrate of CYP3A4 and isn't induced as, well, I think it is actually, Gary can comment, but not as much as itraconazole and isn't induced as much by rifampicin. And so they can be used together, as we do very often. And so to substitute itraconazole for fluconazole for the duration of the TB treatment, and then go back to itraconazole for, you know, maintenance consolidation therapy for the fungal infection. Fluconazole seems to be inferior to itraconazole for this infection. There haven't really been head-to-head controlled studies, but the studies that have looked at fluconazole have looked at it for induction and maintenance. But if you kind of extrapolate from these studies and compare the maintenance treatments after amphotericin between itraconazole and fluconazole, it seems like the main difference is increased relapses with fluconazole, not really an impact on mortality. So we think this is quite a relatively safe temporizing measure to put patients on fluconazole, finish TB treatment, and then go on to the preferred treatment of itraconazole. So those are basically the two approaches.
Thank you very much, Sean. Gary, I wonder if you'd like to make additional comments on the drug-drug interactions and therapeutic approaches.
Yes, sure. I Sean's covered most of it. I think key clinical lessons in this case. First of all, when someone presents with TB symptoms and a papular rash, you have to consider deep fungal infection. I've seen histoplasmosis in HIV without the skin rash. Then it's very difficult. It looks just like TB. But the skin rash is an incredibly important clue, and you should biopsy it urgently. So they should have considered the fungus at first presentation. The second issue is when the fungal infection was finally diagnosed, the TB therapy should at that stage have been reviewed and stopped, because there was no evidence for it and everything could have been explained by histoplasmosis. And the third error was not considering the drug-drug interaction. As a clinician, if you're prescribing a drug that is a strong inducer or a strong inhibitor, like phenobarbital, carbamazepine, rifampicin, or a whole list of strong inhibitors, you have to know that and you have to check. And there's a massive interaction with itraconazole, which you cannot overcome by increasing the dose. Sometimes you can switch to rifabutin, but as Sean says, rifabutin also reduces itraconazole. And although it hasn't been studied with itraconazole, there's evidence from other azoles that they increase the concentrations of rifabutin. So there's a bidirectional interaction. And then the final point is that the rifampicin induction takes a couple of weeks to wane. Most of it's gone by about a week or so. So you would need to protect this patient for a week or so with amphotericin B. But Yunus Musa up in Durban has got a lot of experience with treating TB and deep fungal infections. And he's had good experience with fluconazole. The earlier studies used very low doses of fluconazole, but if you use a decent dose, I think it's a good alternative if you have to treat for both. But in this case, the TB therapy, I think, should have been stopped once the diagnosis of histoplasmosis had been confirmed.
Thanks, Gary. Very helpful discussion. Now, there's a hand from 01337742. I'm not sure who that is. Would you like to ask your question?
Yes, it's me, Ian Ross. Thank you. I go by a number.
Please go ahead, Ian.
So it just reminded me that disseminated histoplasmosis can cause adrenal insufficiency. And given his fatigue, one wonders if that may have been the first manifestation, although it hasn't been considered. And then the two drugs which of themselves can cause hypoadrenalism. And so I just wanted to remind people that in the setting of this cocktail of events, hypoadrenalism or primary adrenal insufficiency is distinctly possible. His low CD4 count, the possibility of disseminated histoplasmosis, and the addition of drugs which lower glucocorticoids may in the future cause it. And it's often difficult to predict when it's going to happen, but I think it is worthwhile that he's screened for it.
Thank you very much, Ian, for those important comments. So, ladies and gentlemen, we've run by 10 minutes over time, and I would like to thank our three speakers for the fantastic presentations today, as well as the contribution of everybody else, and you for your attendance. Keep well. Bye.